withhold and withdraw life supports in the Thai context. First of all, many people said life is like a river. We flow on the unstoppable way. When the time flies, we flow on the water along the river. When we have life, we enjoy our life. We look at the beautiful scenery on the left, on the right, and we enjoy them. Most of the river, we expect our river life should be long and straightforward without any difficulty. But in the reality, life is not easy like that. The river also have a lot of curve, left curve, right curve. And they also have something happen in the river life. This is the old river line. When the times go by, sometimes we need to change our path. Life is like that. And every river also have the end point. This is a Niagara waterfall. Everyone afraid of end point. Niagara Fall in some season is very look dangerous. It's just an enormous waterfall. Someone afraid to go there. But in the winter season, we can see how beautiful it is. This is like the end of life care. How we can convey the patients and family to perceive that at the end of life is not a dangerous situation. This is a beautiful situation, and they will remember in a positive way all the rest of their life. I think everyone have the same thing. We don't want to die. But if one day we have to, how would they want to be in the dying process? When the final days come, which one do you want to be like? Do you like to be at the ICU at this one? Anyone? No? This is it's like your everyday situation in the hospital, in the busy things, and a lot of equipment. The second choice, palliative care always have choice, okay? The second choice, maybe stay in the hospital, in the hospice, with a comfortable environment, with family, with someone you're familiar with. Do anyone like this? Okay. Many people like this one. And the last choice, the third choice, is these patients stay in these patients stay in their house, in their memory house, that everything they know, every place, they feel comfortable in every moment, they know where is everything, and family members stay with them. Do you like this one? Okay. Because all of people here is a palliative care team, right? But for the others, for the critical care, for the other specialty, and for the public people, do they prefer like us? This is a difficult situation. Back to the previous slide, I think everyone, when they know they don't have a chance to get a better, to recovery and survive, they want to stay comfortable way. But do they know the situation, the real situation, the every information that they can decide to the right way? This is important, and this is our duty. So this is a definition of withhold and withdraw life support. Withhold life support is we do not start or increase the level of life support. Withdrawal is we stop or step down the level of life support. It's quite similar thing. But for the practitioner, they have a bit larger perception of these two words. We will figure out after this. When we talk about life-sustaining treatment or life support, most of people think about mechanical ventilators, endotracheal tube, but in the end of life, they have many things considered as life support, such as IV fluid, artificial nutrition, antibiotics, tube feeding, CPR, inotrope, dialysis, ECMO. All of these are life-sustaining treatment. For the public perception, someone perceives that withhold and withdraw life support is killing the patient or hasten the death, make the patient die earlier than it should be. But in fact, it is not. And I think all of us in this room, we know this. Withhold, withdraw life support is we just relieve the suffering on the last moment, last day of life. In English, I like this word, imprison. It's like at the ICU, we have a lot of restrained patients on the bed. We restrain their arm, we restrain their legs. Sometimes the patient have a lot of agitation. They also restrain the chest. So the word imprison is just give all of this thing out. Let them freedom again at the end of life. And all of this is just a process that we call around natural death. No one can survive forever. So when we look at withhold and withdraw life support, is it equally or it's different? So when we look at the outcome is the same thing. Is we around the natural death. Sorry, death, not death. Different thing is about the time of suffering. When we consider to withdraw life support, we just let the patient back to the natural way. We did not postpone the death. We did not go on the process of prolonged death. The intention is the same thing, to let the patient go to the comfortable way. And in the double effect, sometimes the patient maybe when we compare in a lot of life-sustaining treatment or withhold or withdraw life support, it's look a bit shorter. Sometimes think, oh, this is the one thing that they concern. But when we look at the intention, it's the same thing. For the ethics, withhold is equal to withdraw life support. For the moral, this is a big thing. Many people feel uncomfortable when they need to face the situation of withhold or withdraw life support, or about the discussion about withhold or withdraw life support. This is an article from Switzerland. This article, they present about the continue of the treatment, withhold and withdraw life support at the end of life care. You can see about the number of withhold and withdraw life support. Most of intervention, such as artificial hydration, antibiotics, nutrition, ventilator, surgery, chemotherapy, most cases was performed withhold more than withdraw life support. By the way, around 50% and over, they stop the invasive, they stop the intervention. But not only you that feel that more comfortable with withhold or withdraw, even the physician in Switzerland also have this feeling. You are not the one who feel this. When we consider about the care setting, The number one is hospital, second is nursing home, and third is in the patient's home. In every column, the first one is artificial nutrition, antibiotics, artificial nutrition. Oh, sorry, the first one is artificial hydration. The third is artificial nutrition. Hospital is the place that they get a lot of this. So that's why palliative care, we try to move the patient back to their homes, they get to the family environment and less life-sustaining treatment. When they ask the doctor, should they comply with a competent patient request to withdraw life support? More than half, they said yes. If the patient have a conscience and ask to withdraw life support, they said, oh, okay, it's a patient autonomy. If patient requests, patient know benefit and harm, it's okay to follow the patient wish. When they ask about the physiological difficulty between withhold and withdraw life support, more than half of doctors said they feel agree that withhold is more comfortable for their emotion than withdraw life support. And when we talk about ethically, they say the same thing. They think, I say they think, in the ethical way, withhold is better than withdraw. Just for their perception. But when we see the real world, withhold and withdraw life support was performed more than 20 years ago. In every country, withhold and withdraw life support was done, especially in the developed country. You can see in some article, 90% they withhold, withdraw life support. And in one article in Hong Kong, 11% of family members ask the doctor to withdraw life support. Even in Asian culture context, they also have the feeling of suffering, burden, and ask physician to withhold and withdraw life support. Not only for adult, for the pediatrics. In all country in the world, they also have like at least 1/3 to maybe a half to withhold and withdraw life support. It's a normal procedure in the ICU. When physician put it in and when it's no longer benefit, we just put it out. This is a systematic review on withhold and withdraw life support in the ICU. More than 56 articles was included in this systematic review. Mostly, the articles are published in North America and Europe, and only few in South and Central America and Asia. Most of the article was done in the general ICU or mixed bed ICU. We see it's when we look at the mean or the median, it's around half of the patient, around half of the article that they said withhold and withdraw life support is normally procedure that they do in ICU. But we can see in some article, they have only withhold and no withdraw life support. They also have some a bit feeling, maybe a bit guilty or moral distress to do a withdraw life support. So when they ask the intensivists about the withhold and withdraw life support, which one they think it's ethically to do? When we consider as the first one is vasopressin, mechanical ventilator, intubation, and tracheostomy. This is the area that the doctor said withhold and withdraw life support is different in the ethical view by their own. Also include oxygen supply, IV fluid, and oral suction. When we ask the doctor why we do withhold and withdraw life support, around 60% they think when they found there's this medical futility, that it's mean there's no benefit anymore to do intervention, to stay in the ICU, to on the mechanical ventilators. Poor prognosis on chronic disease, poor prognosis on acute illness, and then it's a poor quality of life, patient wish, and autonomies. So in our palliative care life before we face with a lot of cases with a difficult situation that we need to decide. Mr. A, 63 years old with advanced cardiac. Sorry, what time is that? Oh, okay, it's countdown. Okay. So Mr. A, 63 years old man with advanced cardiac disease. The patient had a full comfort, advanced care planning, and already did living will. A grandson found he collapsed on the floor. The grandson took him to the emergency room. Physician in the emergency room also put the ET tube in. Can we take ET tube out? Do you think can we take out? Patient already have advanced care planning and already signed advanced directive. Do you found it easier if we see their advanced care plan and we don't put the tube in? Is it easier or is the same thing? Someone said it's the same thing. Someone said if don't put in, it's easier than take the tube out. When we talk about medical futility, the definition is also the intervention, the treatment is pointless, not useful, no benefit, and not aligned with the patient goal, or the burden is more than the benefit. One thing that we heard in this 2 day of a conference is a shared decision making. Even in a chronic kidney disease or in the ICU, in the emergency room, we also talk about this shared decision making. It is important to include patient into the decision. Very, very important decisions such as withhold and withdraw life support. And healthcare provider as an expert of a medical. And it's also important to bring the family in and heard what is the patient want, what is the patient wish, patient preference. It's more easier for family member to honor what patient said. When we talk about the shared decision making, the first one for the medical team, we should have the well-rounded medical concept, well-rounded medical situation. We need to know which treatment will get benefit, which treatment will not. And when we bring the patient come up with their autonomy. And the other things, family member, psychosocial, financial, caregiver burden is a circumstance that we need to bring in into the shared decision-making process. But it is not like you give 100% to family member to decide. We need to stress it is shared decision-making. When we know this, when we know if one intervention that is 100% no benefit, we should not ask them to perform this intervention. We should avoid this intervention. Debt literacy is very important for withhold and withdraw life support. If patient and family members they knows about their disease, the situation, they have a knowledge about healthcare, palliative care, advanced care planning, it's easier for them to understand and accept about the situation. They need to have a skill to communicate inside the family and outside the family, help patient, family, and a bigger family and social to understand the situation. They need to have availability to access to the resource for support for the healthcare and for the palliative care. And we need to understand about the culture, spiritual, and the meaning of life and death of patient and family. In Thai context, death is taboo. Many people avoid to talk about advanced care planning, withhold, and withdraw life support. In every place, we have the same thing, especially in the Asian culture. Second one is the gratitude, repayment for parents, or in Thai we call katanyu. This is the thing that a family member come and ask. We need to do everything. We need to done everything. But when the healthcare provider heard about we need to done everything, we just need to step back and rethink. Do they really need to do everything? Or they just need to do everything that benefit and no harm for their parents? If they know that there are no benefit anymore, it cause more suffering, cause more harm. After discussion, most of them say no. Oh, okay, we accept. And late consultation culture. I think in the past, maybe in the 1/3, patient already have a ET tilt in when see palliative care team. So that is difficult to avoid withhold and withdraw life support if we don't have a advanced care plan decision beforehand. So we face a lot of situation about this. Patients, family members, and also other healthcare provider try to avoid withhold and withdraw life support. Even just discussion, care planning, or in the process of withhold and withdraw life support. In Thai context, primary care doctor, they don't provide withhold and withdraw life support. So it's different from country to country. In Thailand, most of this kind of procedure was performed by palliative care team. And it have like a two-sided sword. In the one way, it's a good for family members and for patient to have someone to perform this kind of procedure. But the other hand, primary care doctor, they also have a feeling that withhold, withdraw life support is not their duty. It's other kind of doctor duties. So we need to integrate this. We need to do withhold and withdraw life support in the primary care doctor hands. About the competency and regulation is very different from hospital to hospital. In a private hospital, it's rarely to do a withhold and withdraw life support. In the tertiary care hospital, it's unavoidable to do a withhold withdraw life support because we have a lot of severe serious illness patients. In secondary care, I mean in a secondary hospital or district hospital, most of them did not perform this kind of treatment. Barrier and challenge to withhold and withdraw life support in Thai context. Firstly, is ourselves, our team, our healthcare provider teams. We need to have a good attitude about the withhold and withdraw life support. This is one of the options of care. At the end of life, they don't have much option. Continue the treatment, maybe stay longer a bit, but the patient experience a lot of suffering also from their disease and also from our intervention and treatment. Secondly, is withhold life support. Okay, it's better than continued treatment. The third one is withdraw life support. So we need to improve our attitude, moral, and we need to learn more and familiar about this procedure, familiar with about the ethicals of withhold and withdraw life support. The secondly is family members and other person that they have a bad perception about the withhold and withdraw life support. The third one is about the circumstance, such as hospital regulation, culture, religion. But for the culture and norm of the people, it can change time by time. We just increase a bit of integration day by day, time by time. Helpful technique to facilitate withhold and withdraw discussion. The first one that we use oftenly is empty chair technique. When we discuss with the family member about the situation, about the disease, the prognosis, option of care, we can ask the family member, if your parent sits next to you and he know all of information that we're discussing, do you think what your parents want to do? As a family member who know the patient well, they will just sit and need to rethink which one is my parents want. It's better than just ask the family member, what do you want to do? Because that will bring the want from family, not from the patient, not the patient best interest. The second one is a frame up technique. And the third one is communication technique and skill. That is very important. For the frame up technique, at the first time that we see the patients and family members, in many cases, they have like a continued treatment as long as possible. We need to shape up, frame up when we found that it's the end of life care and there's no chance to recovery. If we can talk about withdraw life support and get the agreement from the patient or family member, is the best thing. To withdraw endotracheal tube, ventilators, antibiotic, inotrope, IV fluid, and blood component. But if they don't accept at that time, we can negotiate. We just need to learn how much they accept, what is their preference. Just step back a bit to withhold some interventions such as CPR, medications and interventions. And sometimes we need to step back one more step to time limited trial that Professor K. Ushi also said in the morning session. For the effective communication, we need to aware about three main components. The first one is ourselves, message that we send out, and the receiver means family members. And we should have a good attention to pick a group when we have a discussion. What is the golden phase, such as my parents want to stay independently. He don't want to stay into the mechanical for the whole life, something like that. We need to bring that words that phase into the later conversation. We need to have a facilitation technique to navigate, to direct the conversation. For the communication, I think most of us are focused on the what we said or words, but it's just only 7% of communication. More than half is about body language that the patients and family members can perceive. What is our intention? Do we want to help them sincerely, or we just want to make the bed available? The other thing is tone of voice. How is our tone? How can we pause? Non-verbal have many things that the patient can recognize our intention of discussion, such as eye contact, gestures, space, posture, physical contact, special expression. Other technique is active listening. So active listening is we sit with them and we attentively listen what they say without interrupt. It shows we uh, understand, we respect them, and we can reflect what they said. We can reflect what they said, reflect their emotion, or we can use a paraphrase. And we can and at the end of the conversation, we should summarize what the information that we get from the conversation. And not just the words. We need to pay attention on the how is the body language of the family members, their tone of voice, pace of speech, emotion, facial expression, many things that have a meaning. It is make a doctor's patient family member relationship, make a connection and build trust. And this is important for them and for us to convey the conversation. In the conversation, we need to listen, don't judge, don't criticize, don't interrupt what they said, not make an argument. And we try to use a lot of open-end question to let them express what they think, what they feel. Silence technique is one thing that we often use too. Just keep for a few seconds. Make them have a space to think, to crystallize their idea, their emotion. Is better for them to understand the situation and follow our conversation. They also allow time to make a decision for them and empower their autonomy. Empathy. This is a mnemonic of a verbalized empathy. The first one is naming the emotion. Oh, I feel you sad. Do you sad? Do you a bit distressed? Do you anger? Understand about the situation that can cause this emotion. Respect them and support them and explore why they have this feeling, this emotion. And we also, when we give information, we usually use the technique ask, tell, ask. The first one is asking, how much do you want to know about this? How much do you know about situation? Let them tell us first, and then we just give some information and ask them again. What do you think about this situation? What do you plan for this situation? Do the patient have an advanced care plan, advanced directive, or tell you anything about their critical illness decision? This is a kiss pass technique that I learned from Professor Charlie Koch. This technique we use in the ICU when we talk about withhold and withdrawal life support. Just a last kiss to say goodbye to the loved one. The first step is show that we want to know the patients. Please tell me about the patient. This, at this time that I saw the patient, he's already consciousness. Could you tell me about your parents? Second, show your interest more about the patient. So that's make a stress that we want to know the patient. We want to learn about the patient. What is the patient preference, patient wish? The third one is summarize what you have heard from the family. The fourth is strive and struggle. We hope like you. We hope like family member. We try to do many things to make him better, but it's not work. The next S is suffering. Tell them about the risk of suffering. At this point, uh, all of the benefit equipment we was done already. I'm afraid if we do more intervention, we do more invasive thing, it might make your parents more suffer. And focus on the patient preference or patient wishes. As you told me, your parents want dot 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 dot. Acknowledge of love. So, oh, I understand. You want to do this, do that because you love your parents. This is the way you show your love. I acknowledge that. I know how much I can I can feel how much you love your parents. The eighth step is share decision making. We need to stress on the word share. At this point, we need to come to sit together and share our decision. What is the best for your parents? And the last step is suggestion or recommendation. In the in my best of medical knowledge, the best thing for your parent at this moment is 1, 2, 3, 4. Okay. Uh, 10 step to successful withhold and withdrawal life support. The first step, we need to know all about the medical condition, treatment plan from every care team, report all the medical things. We should get the consensus among the medical team before do a family meeting with the patients and family members. Let the patients and family member learn about patient condition and make sure they understand what is the situation is. How about the acceptance level? Do they accept or they have another state of emotion? So now we talked about the situation at this moment. The next is we need to think ahead. What is the future? What will happen in the future? What is the option that we can choose? We need to bring patient preference, value, and goal on the table and talk with the family members. Create a care plan that align with the patient preference by shared decision making and make it happen. For the psychosocial, spiritual, and bereavement care, we need to do at the early step. This domain does not happen at the dying or when the patient die already. It's already happened when the family member know patient will die soon. They get a terminal illness. And the loss and psychological effect happen after that for a long period of time. So this is all of my presentation. All life lead to palliative care. No one want to die with sufferings. ครับต่อไปเป็นภาษาไทย นะครับก็หัวข้อวันนี้ก็เป็นเรื่องของการยุติแล้วก็ถอดถอนเครื่องพยุงชีพนะครับก็อันแรกก็เป็นการที่ชี้ให้เห็นก่อนว่าส่วนใหญ่เนี่ยมันเป็นเรื่องที่คนเรามักจะหลีกเลี่ยงและไม่อยากพูดถึงคนเราคิดว่าเราจะอยู่ไปได้เรื่อยๆอยู่ไปได้อย่างยาวนานนะครับแต่จริงๆทุกอย่างที่มันมีเกิดมันก็ต้องมีจุดที่มันยุตินะครับทำยังไงให้จุดนั้นเนี่ยมันเป็นจุดที่เขารู้สึกว่ามันเป็นจุดที่ยอมรับได้นึกถึงเมื่อไหร่ก็เป็นความรู้สึกที่ดีไม่ใช่เป็นความรู้สึกที่ทุกข์ทรมานนะครับ แล้วก็ชี้ให้เห็นว่าการที่จะยุติเครื่องพยุงชีพเนี่ยเราจะมี2 คำคือ withhold กับ withdraw life support ใช่ไหมครับ withhold ก็คือเราไม่ได้ไปใส่อะไรเพิ่มนะครับ withdraw คืออะไรที่มีอยู่แล้วเนี่ยเราสามารถถอดถอนออกแล้วให้คนไข้เนี่ยเขาก็จะถดถอยไปตามตัวโรคที่เขาเป็นไปตามเส้นทางตามธรรมชาตินะครับซึ่ง withhold กับ withdraw life support เนี่ยในทางจริยธรรมเนี่ยมันเหมือนกันเลยนะครับแต่ในคนปฏิบัติเนี่ยมันจะมีความรู้สึกตะขิดตะขวงใจรู้สึกไม่ค่อยสบายใจถ้าพูดถึงว่าเราจะต้องไปถอดถอนเครื่องพยุงชีพไปถอดท่อใครนะครับซึ่งอันนี้เราเรียกว่าเป็น moral distress นะครับซึ่งตัวเนี้ยมันไม่ได้มีแค่ในบริบทของอ่าคนประเทศไทยหรือประเทศลาวหรือเอเชียแม้แต่ในงานวิจัยของสวิตเซอร์แลนด์เราก็เห็นสิ่งเดียวกันนะครับหรือในหลายๆประเทศเราก็เห็นสิ่งเดียวกันว่าหลายๆคนเขารู้สึกสะดวกใจมากกว่าถ้าจะไม่ทำอะไรเพิ่มนะครับหรือวิดโฮมากกว่าที่จะไปวิด withdraw life support นะครับ แต่พอมาถึงในสถานการณ์ของประเทศไทยนะครับที่ซึ่งคนเข้าถึง palliative care ค่อนข้างช้านะครับบางที่เนี่ย20% 30%ของคนไข้ที่กว่าจะมาเข้าถึงก็คือพะงาบแล้วใส่ท่อช่วยหายใจแล้วด้วยซ้ำมันก็เลยเป็นสิ่งที่เราหลีกเลี่ยงได้ยากว่าเราจะต้องมีความเข้าไปยุ่งเกี่ยวกับเรื่องของ withhold withdraw line support นะครับยกเว้นแต่ว่าเราจะเริ่มเข้าถึงคนไข้ได้เร็วขึ้นมีการทำแผนการดูแลล่วงหน้า advance care plan ได้ก่อนนะครับ มาพูดถึงว่าสิ่งที่เป็นสิ่งที่ท้าทายนะครับในการที่จะทำยุติถอดถอนเครื่องพยุงชีพหรือว่าไม่ใส่เครื่องพยุงชีพต่างๆเพิ่มนะครับอันแรกก็คือทีมสุขภาพทัศนคติของทีมสุขภาพนะครับว่าเรารู้สึกยังไงกับการยุติถอดถอนเครื่องพยุงชีพเรารู้สึกว่ามันเป็นหน้าที่เป็นสิ่งที่เราจะควรทำไหมเป็นเส้นทางหนึ่งของการรักษาที่ช่วยให้เขาได้ไปในทางที่ดีกว่าอยู่กับเครื่องพยุงชีพไปนานๆโดยที่ไม่มีโอกาสจะดีขึ้นหรือเปล่านะครับถ้าเราอันนี้เป็นก้อนใหญ่เลยถ้าเราก้าวผ่านจุดนี้ไปได้จุดอื่นๆเราถึงจะพยายามที่จะก้าวผ่านไปได้แต่ถ้าเรายังก้าวผ่านจิตใจตัวเองไม่ได้เนี่ยอย่างอื่นแม้ว่ามันจะเล็กหรือใหญ่เราก็จะคิดว่ามันเป็นปัญหาซะหมดนะครับเราก็จะไม่ไปทำมันนะครับถัดมาก็คือเรื่องของความเข้าใจของครอบครัวหรือภาคสังคมนะครับที่ว่าการทำอย่างเงี้ยทำให้คนไข้ตายเร็วขึ้นหรือเปล่าฉันเป็นลูกที่ดูแลคนไข้ไม่ดีหรือเปล่าอกตัญญูหรือเปล่านะครับรวมถึงบริบทของศาสนาวัฒนธรรมต่างๆนะครับคราวนี้การที่เราจะพูดคุยหรือว่าการทำวิดโฮวิดดอไลฟ์ซัพพอร์ตให้ได้ประสบความสำเร็จแล้วก็ง่ายขึ้นนะครับเราก็ต้องทำให้คนไข้และครอบครัวเนี่ยเขาเข้าใจก่อนนะครับถึงสถานการณ์แล้วก็เส้นทางต่อไปที่มันจะเกิดขึ้นมันมีทางเลือกอะไรบ้างนะครับที่เราจะสามารถเลือกได้แล้วมันตรงกับเป้าหมายปลายทางจริงๆสิ่งที่คนไข้เขาต้องการหรือเปล่านะครับเป็นเรื่องสำคัญที่เราต้องรู้ว่าความต้องการคุณค่าเป้าหมายของคนไข้คืออะไรถ้าเราได้ตรงนั้นแล้วเนี่ยความการทำมาตรการต่างๆเนี่ยมันก็จะง่ายขึ้นเพราะเราก็จะรู้ว่าเป้าหมายปลายทางคืออย่างนี้เราจะเดินเส้นทางถนนเส้นไหนเพื่อให้ไปถึงปลายทางตรงนั้นนะครับ ก็ได้มีการพูดถึงเทคนิคต่างๆเนาะเทคนิคเก้าอี้เปล่าหรือว่าการค่อยๆจัดกรอบการวิดโฮวิดดอไลฟ์ซัพพอร์ตให้มันแคบเข้าคมขึ้นเรื่อยๆนะครับรวมถึงเรื่องของการเทคนิค Kiss Pass ที่ใช้ในการพูดคุยตอน withdraw line support แล้วก็เทคนิคการสื่อสารในหลายอย่างที่เราใช้ในการคุยเพื่อ ยุติถอดถอนเครื่องพยุงชีพโอเคมีคำถามไหมครับ
ขอบคุณอาจารย์อัธกรค่ะI'll ask in English and then translate to Thai. As if we have two sides of coin, since I started practice palliative care, I it was easy for me to withdraw ventilators. But when more doctors, more team know more about palliative care, we have more cases asked for withdrawal. Then right now, to be honest, it's so difficult, and I have moral fatigue, and sometimes we just delay because I'm not sure. What I worry is premature death, and it's not the right time to do it. And what I would like to ask you is how you deal with it, how you manage to make sure we really do the right thing. ก็คือว่ามันคือตอนเราเริ่มใหม่ๆเราก็จะกล้าทำนะแต่พอเราทำมาสักระยะเคสที่มันเยอะขึ้นเพราะว่าตอนนี้สถานการณ์ของโรงพยาบาลรัฐเนี่ยต้องยอมรับว่ามันบีบคั้นมากแล้วก็เตียงเรามีจำกัดอันนี้นั้นเราได้รับเคสแบบนี้เยอะขึ้นมากๆในขณะที่ advanced care planning หรือ advanced directive มันเริ่มมามากขึ้นตอนนี้ในที่คนที่ palliative เข้าถึงเราจะเห็นว่าเคสมันเยอะซึ่งมันสร้างความลำบากใจให้เราอยู่พอสมควรค่ะก็เลยจะถามอาจารย์ว่าเราจะดีลกับเรื่องนี้ยังไงอาจารย์มีเทคนิคทำนี้
Very good question. For my practice, I don't have a good answer for you. I have the same situation. But for the ideally, I think as we learned from the 2 days of conference, it's about the integration and let other specialties step in, and we need to step out. We may need to teach their faculties, their doctor specialty and their residency, how to perform. As I mentioned before, we bring all the end-of-life care and extubation in our ward. So other kind of doctor don't have any experience about withhold and withdrawal life support. So the other step, we have a fundamental thing, we have do everything, and we have a confidence, our palliative care are confident with this medical procedure. We need to step out again to withdraw life support in another ward, in another ICU, and just step in a bit, let them participate in withhold and withdraw life support. Even discussion and also the process of withhold and withdraw life support. It may take time, 3 months, 6 months, or maybe years. And at the one time, they can perform withhold and withdraw life support by themselves. In many countries, such as Australia, primary care doctor, they withhold and withdraw life support before consult palliative care. But in Thai, we have a very good mind. If another one don't do something, okay, I can do. At the one time, everything is our own, and they learn. Just let the palliative care do. We don't need to do that. So we need to change this culture. ครับก็กลับมาเป็นภาษาไทยนะครับก็คือที่อาจารย์น้ำทิพย์ถามนะครับผมก็บอกว่าผมก็ลำบากเหมือนกันนะครับเราก็เจอสถานการณ์เดียวกันพอเขาอยากให้เราถอดถอนเยอะขึ้นเราก็จะเริ่มทำไม่ไหวเพราะเราก็มีบุคลากรจำกัดนะครับสิ่งที่เราได้เรียนรู้มาในช่วง2 วันนี้ก็คือทำยังไงให้เกิดการสอดประสานระหว่างทีมประคับประคองแล้วก็ทีมแพทย์เจ้าของไข้นะครับทั้งทีมแพทย์ทีมพยาบาลเจ้าของไข้ที่สถานการณ์ของเราเราเอาคนไข้ที่จะถอดถอนเครื่องพยุงชีพมาที่วอร์ด Palliative แล้วเราถอดถอนเองทั้งหมดนะครับสิ่งที่เกิดขึ้นก็คือทีมเราก็มีความรู้มีความมั่นใจในการทำหัตถการสิ่งเหล่านี้แต่ในขณะเดียวกันนะครับเราก็พลาดโอกาสที่คนอื่นๆจะได้เห็นการทำหัตถการเหล่านี้ withhold withdraw life support นะครับเพราะฉะนั้นในสเต็ปถัดในขั้นตอนถัดไปพอเรา องค์ความรู้เราแน่นทุกคนเชื่อมั่นว่าสิ่งเนี้ยมันเป็นสิ่งที่ทำได้นะครับแล้วมันก็ทำได้ถูกเราก็ควรที่จะเริ่มค่อยๆขยับออกไปทำในหอผู้ป่วยอื่นแล้วก็ค่อยๆให้อ่าอาจารย์ของเขาหรือว่าหมอเรสซิเดนต์ของเขาเนี่ยค่อยๆเข้ามามีส่วนร่วมทั้งในเรื่องของการพูดคุยแล้วก็เรื่องของการทำหัตถการ withhold withdrawal life support นะครับอาจจะค่อยๆเริ่มวันละนิดวันหน่อยอาจจะให้แค่เขาเข้ามาดูค่อยๆให้เขาเข้ามาทำแล้วเขาค่อยๆซึมซับจนวันหนึ่งอาจจะใช้เวลาเป็นเดือนหรือเป็นปีณจุดหนึ่งเขาก็จะสามารถทำได้ก็จะเหมือนกับประเทศอื่นๆที่หมอเจ้าของไข้เป็นคนทำสิ่งเหล่านี้
ท่านใดมีคำถามเพิ่มเติมไหมคะ ในห้องส่งค่ะในซูมไม่มีคำถามเพิ่มเติมนะคะ
So thank you very much.
yes,
Oh yes, we
more
have
question.
more question.
สวัสดีค่ะ so I just wanna get some advice from you about how to deal with withdrawal support for the family of healthcare provider because I've been suffering from a few months later because all of them want to do the best and want to do like as much as they can without make the patient suffer. So can you give me some advice for that? Thank you. ค่ะจะถามว่าต้องแปลไหมคะค่ะคือจะถามว่าช่วงหลังมาเนี่ยค่ะเราต้องได้รับการปรึกษาให้ไปดูแลคนไข้ญาติของคุณหมอพยาบาลที่โรงพยาบาลค่ะก็จะมีปัญหาว่าเขาอยากทำให้ถึงที่สุดทำมากกว่านี้อีกก่อนที่จะ withdraw life support หรือบางทีเราคุยกันมาก่อนหน้านี้แล้วว่า advance care plan คือ comfort แต่พอถึงเวลาจริงๆเขารู้สึกว่าขออีกนิดได้ไหมถึงที่สุดหรือยังรวมถึงกิ้วที่เกิดขึ้นหลังจากที่วิดดอไปแล้วก็จะมีคนรู้สึกว่าแบบเอ๊ะหรือพี่ยังไม่พอหรือพี่ยังทำไม่สุดอย่างเงี้ยค่ะ
I can feel your emotion, your distress, and this is a difficult situation that we found in Thailand. So I think as they are medical team, they know they have like a 1, 2, 3 step to do more intervention, invasive thing. But just step back at why they want to do them. It's not because they are medical team, it's because they are son, they are daughter, they are human. They just want to do the same, they just want to do the best thing for their parents. And this is the way they show how much they love their parents. So we need to sit, talk with them. What is your ultimate goal of this care? What do you think this intervention help? What is your father or mother preference? Sometimes it's maybe emotional support. It may be frustrating. It may be guilty. Something that they just need to do like a gratitude for their parents. So I think it's about the emotional and spiritual distress of the family members. So that we need to sit, explore, don't judge them at the first time, at the first meeting. Sit with them. Can I be friends with you? I need to learn about your parents' life, about your life. What do you think about the situation? Yes, I think this kind of approach might help ครับก็เป็นอะไรที่เราเจอเรื่อยๆนะครับแต่ว่าจริงๆแล้วสิ่งที่เขาขอเนี่ยเหมือนเพราะว่าเขารู้ว่ามันยังมีอย่างอื่นที่สามารถทำได้ใช่ไหมครับแต่ถ้าเราถอยกลับมาแล้วเนี่ยจริงๆแล้วสิ่งที่เขาในฐานะมนุษย์คนหนึ่งต้องการเนี่ยในฐานะลูกคนหนึ่งต้องการก็คือทำยังไงให้ดีที่สุดทำยังไงให้ไม่ติดค้างทำยังไงให้ฉันเป็นลูกที่กตัญญูแล้วนะครับสุดท้ายมันอาจจะกลับไปตรงมิติที่ว่าจ จริงๆอะไรคือสิ่งที่คนไข้ต้องการอะไรคือเป้าหมายปลายทางสุดท้ายนะครับและเขาคิดว่าสิ่งที่เขาทำไปมันจะมีประโยชน์หรือโทษยังไงจริงๆไหมกับคนไข้นะครับสุดท้ายก็ต้องมานั่งคุยกันนะครับให้เขาได้มีโอกาสพูดระบายแล้วก็ซัพพอร์ตนะครับมันน่าจะเป็นประเด็นเรื่องของเรื่องอารมณ์เรื่องของจิตวิญญาณที่เขายังรู้สึกมีบางอย่างติดอยู่ยังรู้สึกว่าเขาได้ทำอย่างเหมาะสมเต็มที่หรือยังซึ่งถ้าหากเราทำในสิ่งเหล่านี้ได้ดีแน่นอนมันจะไปช่วยเรื่องของ bereavement care หรือว่าการโศกเศร้าสูญเสียด้วยนะครับมันก็จะช่วยทั้งให้คนไข้มันจะเป็นการปลดล็อกของญาติต่อคนไข้และปลดล็อกญาติต่อตัวของเขาเอง
Thank you, Dr. Attakorn. So we have one more question from online. This question, so the translation is they want to know about the protocols or the best practices for withdrawal of life support so that the healthcare team would not run into any legal problems. ขออนุญาตเรียนถามเรื่องการถอนเครื่องพยุงชีพมีแนวทางโปรโตคอลสำหรับทีมเพื่อไม่ให้เกิดปัญหาทางกฎหมายภายหลังอย่างไรครับ
So I think this have two main things. One is about the legals, one is about the protocol. So for withhold and withdrawal life support, the first thing is about the concept. And for the question, I think the withdrawal that he mentioned is maybe about the mechanical ventilators, right? Okay. So we also have a protocol to withdraw life support. You can, I think this is in our website, in karunlak.org. You can go in and find the documentation for withhold and withdraw life support, integrated care pathway, and also we have a bereavement 2 days. And about the legals is about, from Thailand, right? Okay. So in Thai, we don't have the law that said they're not allowed to withhold or withdraw life support. We need to look separately, legals and medicals. They have a bit intersect, but for the legal parts, they don't want to come into the medical part because this is a medical decision making, not the legal side. So they have like a privilege for healthcare team to decide which one is benefit, which one is harmful to do with the patients. So for the law, I think there are no problem at this moment, but it's about the knowledge, the attitude, moral distress. Oh,
Translate the answer, please.
ครับ มันมีอยู่2 อันใช่ไหมครับ อันแรกคือเรื่องกฎหมาย อันที่2คือเรื่องของโปรโตคอลนะครับ ซึ่งโปรโตคอลของการถอดถอนเครื่องพยุงชีพถอดท่อเรามีอยู่ในเว็บไซต์ของศูนย์นะครับแล้วก็สามารถเข้าไปดูตรงนั้นได้นะครับ ส่วนเรื่องกฎหมายเนี่ยประเทศไทยเราไม่ได้มีกฎหมายที่บอกว่าห้ามนะครับการยุติถอดถอนเครื่องพยุงชีพในเคสที่เป็นระยะสุดท้ายของชีวิต เรายังมีกฎหมายด้วยซ้ำที่บอกว่าคนไข้เขามีสิทธิ์ที่บอกว่าเขาไม่อยากใส่นะครับและจริงๆทางฝ่ายกฎหมายเขาไม่อยากยุ่งกับการแพทย์มากเพราะว่าเขาไม่ได้มีองค์ความรู้ทางด้านการแพทย์ว่าอันไหนมันมีประโยชน์หรือมีโทษเขาให้เป็นหน้าที่ของทีมแพทย์ที่บอกว่าอันไหนมันมีประโยชน์มีโทษกับคนไข้แล้วเราต้องตัดสินใจทำในสิ่งนั้น
ครับขอบคุณครับ so thank you one more yes
I like to make some comments. So withdrawal life support is a medical procedure. So if you have a shared decision making and informed consent, say, but you need to evaluate who is the real proxy. So you need an informed consent, and it should be done by the health professional. คือเขาถามว่าจะทำยังไงอย่างปลอดภัยนะตราบใดคือเราต้องยอมรับว่าการใส่ท่อเป็นmedical procedure การถอดนี่ก็เป็นเหมือนกันนะด้วยคนที่ทำอันนี้ ก็ต้องเป็นทีมบุคลากร และจะต้องมี informed consent ก่อนเขาจะใส่ท่อเขาจะต้องมาขออนุญาตให้เราใส่พอเราจะถอดถ้าเขาเซ็นอนุญาตให้เราถอนท่ออันนี้ก็เป็นสิ่งที่ทำได้ เพียงแต่เราจะต้อง evaluate ให้ดีๆว่าคนที่เป็นคนตัดสินใจหลักคนนั้นน่ะคือใคร
ขอบคุณค่ะ จริงๆ มันมีพาร์ทหนึ่งที่สำคัญมากแล้วอยากผลักดันให้ทุกโรงพยาบาลทำก็คือมีคณะกรรมการ Hospital Ethical Committee เพราะกรณีนี้มันเป็นเรื่องของไดเลมม่าค่ะ เพราะฉะนั้นถ้ามันมีเนี่ยมันจะช่วยให้ทีมสุขภาพลดเบอร์เดนในเรื่องของการต้องตัดสินใจค่ะ ซึ่งอันนี้อยู่ในHospital Standard Thailand ก็อยากจะฝากว่าตอนนี้มันมีช่องทางให้เราเอาเรื่องเหล่านี้มาคุยกันบนโต๊ะค่ะ
So thank you so much, Dr. Attakorn, for your wonderful lecture.